another case. I love cases, and I love starting with cases because it kind of gets you to think about what's going on. So, you're working in the emergency department again, and you get a 42-year-old female. She has a past medical history of hypertension, and she's coming into the emergency department with a chief complaint of shortness of breath. And she looks like this. She doesn't look very, very well at all. You look at her vital signs, and they're a little abnormal. She's tachycardic. She's hypertensive. She doesn't look well. So you get a temperature on her, and the temperature is elevated. So what happens when your hospital sees a patient with an elevated temperature? You're supposed to freak out. You're supposed to get all crunk and hype, and everybody's supposed to freak out because we all know that we can't miss the sepsis. We can't miss sepsis, so you know it's a sepsis alert. So they're going to do all of the things. So you do all the things. You go sit down at your computer, and you start putting in orders on this patient. I need fluids. I need gorillacillin. I need bomomycin. I need all the antibiotics. I need vasopressors. I need all of these things. Let's get the 30 cc's per kilo going on this person. But then you start to do those things and she's not getting better. Things are not going in the right direction. But this is sepsis, right? She's febrile. She looks like she's septic. She doesn't look well. I don't really know what else is going on. And then you get that chest x-ray back and you're like, oh crap, she's got fluid in her lungs. I just gave her 30 cc per kilo bolus. Did I do this? Is this something that I did? Did I cause this problem? And her blood pressure is not getting better. Her heart rate's not getting better. When we do the things that we're supposed to do for sepsis, they're supposed to get better, right? Their vital signs are supposed to improve. Their temperature is not getting better. Her heart rate's not getting better. Her blood pressure is not getting better. She doesn't look better. What else could be going on? But while you're sitting there, she gets up out of bed. She's arguing with people. They're trying to figure out why she won't stay in the bed. She just looks very uncomfortable. She's setting lower. Her oxygen saturation is now in the 80s. You put her on 100% non-rebreather. It's not improving. So you end up intubating her. Now you're really perplexed. What in the world is going on with this febrile patient who also has signs of heart failure but doesn't look like sepsis? Got to think about the thyroid. Is it the thyroid storm? It ain't sepsis. It must be that thyroid storm. So when we think about people who come in with tachycardia and fever, a lot of times we hear those hooves. And when we hear those hooves, we think about sepsis, which is the horse. But then there's other things that we also think about that are kind of more of the zebras. And a lot of people think of thyroid storm as a zebra. Really? It's not a zebra. Really, it's a unicorn. We don't see a lot of thyroid storm. So a lot of times when we see patients who come in with thyroid storm, we don't consider this diagnosis. We think about the things that were more common to see: sepsis, pneumonia, urinary tract infection, nausea, vomiting, and diarrhea from a gastroenteritis, right? Those are the things that we more commonly think about. But we have to remember this unicorn, because if we miss this, patients do badly. The mortality rate for thyroid storm is up to 30%, which means that 3 out of 10 patients that you see with thyroid storm, regardless of your treatment, you're going to probably end up having a bad outcome. And the reality is that we miss this diagnosis more commonly than we catch it because we don't consider this diagnosis in this patient population. So why does this happen? What's the pathophysiology? Any biochemistry nerds know what this is? It's a beta receptor. Come on, guys, you don't remember your stuff? It's a beta receptor. Of course it's a beta receptor. Well, what happens with thyroid storm is thyroid hormone causes the body to express lots and lots and lots of beta receptors. And those beta receptors are what causes the systemic effects that we see with these patients' blood pressure, their heart rate, their temperature. And so we have to be monitoring these scenarios in this patient population. This is what causes that systemic increase in their vital signs. But when they start to manifest end organ damage, they start to develop things like jaundice, the nausea, the vomiting, and then at the end stage of thyroid storm, the altered mental status. And that agitation and altered mental status is what commonly causes us to think about thyroid storm, which in most circumstances, when it gets to this point, it's probably a little bit too late. So the biggest pitfall here is when you see a patient with fever and altered mental status, don't think about anything else but thyroid storm. Obviously, I'm joking, because there's a lot more things that do commonly manifest in our emergency departments with fever and altered mental status. And this is just a list of some common things that we are more likely to see with fever and altered mental status. However, the difference between those and thyroid storm is you're probably going to get a really good history that will help you come up with the patient who's got cocaine intoxication, with alcohol withdrawal, with CNS infections, with sepsis. And with thyroid storm, the patients may not know that they have an underlying thyroid condition. So it's going to be much harder to think about this diagnosis because your history may not help you unless you're really diligent or an endocrine nurse such as myself. And I'm going to ask those questions. Hey, have you been noticing some heat intolerance? Hey, have you been noticing that you've been losing weight? Hey, have you been noticing that even though you're eating appropriately, that you're still having a lot of vomiting and diarrhea? And I'm going to ask a lot of those questions because I love endocrine emergencies. But if you don't love endocrine emergencies and you don't think about these things, you have to think about this diagnosis as well. So how do we make this diagnosis? Well, there's some scoring systems out there. There's the Birch-Wartowski system, which came out in 1992. And Birch and Wartowski are two very old endocrinologists who practice in Maryland. And they came up with this scoring system. The problem with this scoring system, it's super sensitive. It's very poorly specific. Patients who come in with sepsis will oftentimes meet the Birch-Wartowski system for making the diagnosis of thyroid storm. And the reason why they came up with this scoring system was because a lot of hospitals at the time didn't have free access to getting thyroid function tests, which a lot of us, except for Swami, have access to in their hospital. Then in 2012, the Japanese Thyroid Association came up with the Akamizu criteria, which were a lot more specific, also equally sensitive, but a lot of people don't use that because we have a much more available thyroid function panel that's available. So when you see these patients who come in with fever, altered mental status, just add on a TSH. It's really easy to do. If you get the results back, you can actually affect the management of this patient and probably lead to a better outcome. And then you can add a free T4. Our hospital actually has a TSH with a reflex free T4, which I love. And my residents always know when I'm working that you better order a TSH with a free T4, reflex free T4. All right, so we make the diagnosis. We know that in patients with thyroid storm, more commonly than not, they're going to have a very low TSH and a very high free T4. So we made the diagnosis. Now we got to treat the damn going thing. So how do we treat this appropriately? Well, we know that beta receptors are the primary problem. So the probable fix is going to be your beta blockers. But before you start just throwing beta blockers at patients who you think are in thyroid storm or who you diagnose with thyroid storm, consider that these patients may have gone into heart failure. And so this is where I grab my ultrasound and say, hey, let's make sure this hypertension and this tachycardic and this febrile patient doesn't have signs of heart failure. And I can diagnose this much faster with an ultrasound than waiting on a chest x-ray. So I'll get my ultrasound, look at that EF, and see if that EF is depressed before I add on any beta blockers. There's lots of case reports in the literature of patients who are diagnosed with thyroid storm in the emergency department, get a single dose of propranolol, and go into cardiac arrest because they didn't consider the EF first. So we're going to talk about low EF shortly, but let's say the EF is okay. Well, if the EF is okay, you're going to start with your beta blockers. The very common beta blocker that a lot of people like to use is propranolol, because propranolol, we know, decreases the peripheral conversion of the T4 into the more active T3. In reality, all of the beta blockers do that. It's just that propranolol does it the best. I personally don't like propranolol because it's not easily titratable. So what I personally like to use is esmolol. Esmolol, wrap it on, wrap it off. If they start to show signs of decompensation, then I can turn the esmolol off and it's out of their system very, very quickly. If you have a patient who's intolerant to beta blockers, you may need to resort to using calcium channel blockers, and my go-to calcium channel blocker is diltiazem. Again, I am looking at that EF before I'm giving them a calcium channel blocker to prevent that very precipitous circulatory collapse. Now, we know that beta blockers work great for the systemic blockade, but they don't do anything because there's a thyroid that's out there that's still spitting out a whole bunch of thyroid hormone. So we got to stop this thyroid from making thyroid hormone, because everything that we're doing beta blocker wise is not going to work unless we stop the thyroid from making hormone. So we get the thyroid hormone blockers out there and they take the thyroid out. Propylthiouracil and methimazole. Now, which one is better? Propylthiouracil has been known to cause hepatotoxicity. That's not great in your patient who already may have some hepatic dysfunction secondary to the thyroid storm. So I personally like to use methimazole because it's a little bit safer. There's some reports about a questionable reversible agranulocytosis that happens with methimazole, but I don't want them to be hepatotoxic, so I use methimazole, unless they're pregnant. If they're pregnant with thyroid storm, there are some things that you have to consider. If they're in the first trimester, I like to use PTU. If they're in the second and third trimester, I'll use methimazole. And the little thing that I like to use as a little memory aid is PTU in pregnancy, meaning right when they find out that they're pregnant, and then methimazole in motherhood. As they get closer to motherhood, they'll switch them to methimazole. And a lot of these patients are going to be managed by maternal fetal medicine. And then you're going to give iodine. The big key here is you have to give the iodine after you've given the antithyroid medications. And it has to be greater than an hour later, or else you're just going to tell the body to make more thyroid hormone. Iodine is a precursor to thyroid hormone. So what this does is it prevents the body from making more thyroid hormone when the antithyroid medications are in place. And then you're going to give your stress dose steroids to counteract the autoimmune effects that may be from the patient's Graves' disease, but it also decreases the peripheral conversion of T4 to T3 as well. So I will give them stress dose steroids as well. So this is all stuff that we learn in our prospective schools. But what do we do for the other things that are potentially going on with the patient? We have to remember that a lot of times it's a stressor that brings on the thyroid storm. So if there's a concomitant sepsis or myocardial infarction, PE, stroke, you have to treat those things as well to prevent them from continuing the thyroid storm. What about the other symptoms? Well, we have to support them as well. So these patients are febrile. We like to give them antipyretics, and very commonly we're going to use Advil and Tylenol. Well, your NSAIDs and aspirin are actually contraindicated because those medications actually knock the T4 off of the binding protein, making it more available for conversion to T3. So if you're going to use an antipyretic, use Tylenol. What about if they're super hyperthermic? A lot of our inclinations are to take these patients and dunk them in a big old ice tub of water. That would be very bad to do in your thyroid storm patients. Passive cooling is plenty. So just putting them fan in front of them, turning the temperature down in the room, oftentimes works very, very well for these patients. What if they're super agitated? Sure, you could just give them some IM succinylcholine and intubate them, and I hate succinylcholine. But if you don't have IV access and you don't have any other options, but you can give them some other medications. How many of you guys like the B52 route? Benadryl, Haldol, Ativan. Works okay, but doesn't really work well in your thyroid storm patients because there are case reports of patients who get Benadryl, patients who get Haldol, who subsequently increase their thyroid storm. So my go-to in this scenario is going to be your benzodiazepines to control the agitation in this patient population. And then always be careful about ketamine in this patient population as well. Ketamine does increase catecholamines in patients, and that would be really bad in a patient who has a whole bunch of beta receptors, as in the case with thyroid storm. So I try not to use ketamine in this patient population as well. All right, we know these patients are going to get some fluids, but what if they are volume overloaded? A lot of these patients do need IV fluids, but again, this is where I'm going to get my ultrasound out because I want to differentiate between high output heart failure and low output heart failure. High output heart failure gives you increased contractility, it gives you increased cardiac output, but the systemic vascular resistance is going to be lower in this patient population. But eventually, over time, high output heart failure will become low output heart failure. The heart cannot beat in a hyperdynamic way for a prolonged period of time before developing low output heart failure. So this is where I'm going to use my ultrasound as my friend again to see what their ejection fraction is like. What is the heart actually doing? And in this scenario, treating the heart failure is kind of a slow as you go process. So if they have low output heart failure, you treat it like every other CHF patient you see. You're not going to give these patients beta blockers and calcium channel blockers that are going to further decrease their inotropy. You're going to give these patients preload, afterload reduction, and diuretics. If they're high output heart failure, focus on the systemic blockade, decreasing the heart rate, decreasing the blood pressure with your beta blockers or calcium channel blockers. Afterload reduction and preload reduction is a no-no in this scenario. Diuretics can be used, but a lot of times you're just going to manage these patients with IV fluids, and sometimes you may need pressors to help augment their blood pressure if their pressure starts to decrease. So, big take-home pearls that I hope you got from this talk. Number one, think about thyroid storm. If you forget about this diagnosis, you're not going to make it. And despite all of the interventions that you might do, the patient may still have a bad outcome. Get that TSH. Number two, treat thyroid storm in a stepwise fashion. Again, you don't want to treat these patients with just throwing the kitchen sink at them. Get the medications on board in a timely fashion so that they don't have worsened outcomes. Number three, passive cooling and acetaminophen for your patients with hyperthermia. And then benzos for agitation. And lastly, and most importantly, before you start intervening and giving these patients treatment, get your ultrasound out there. Look and see what that EF is doing. Low output heart failure, treat like CHF. High output heart failure, be really aggressive with your systemic blockade. You will treat these patients appropriately. As always, thank you very much for your time.